Hey guys, welcome to another episode of Foresight TV. This may be Foresight TV controversy. I have got as my guest Michael Wasserman, who has written extensively about the nursing home industry. The thing that really triggered this conversation is the new proposed staffing minimums, which of course we know there are lots of problems with, so we're certainly going to talk about that. But I want to spend a lot of time just talking about what we understand about the nursing home business. But before we get into that, we're going to start with this. Hey guys, Steve Moran here. And I want to start by saying thank you to KARE for sponsoring this episode of Foresight TV. KARE is the place to go if you need to supplement your staffing because you have got empty spots, staffing holes that you need to fill. They take a Uberize app approach to staffing, which means that you get amazing team members to come in and work those shifts that you need people without paying agency prices. And so I would highly recommend that if you're struggling to fill shifts, this is the place to go and keep your costs down. And I would say on the other side, if you are a nurse or you are a caregiver and you are looking for a way to pick up some extra shifts, get paid what you're worth, this is a great place for you to go to supplement your income. They're huge partners. They're friends. They have really revolutionized the staffing, the temporary staffing world in senior living. Dr. Wasserman, I am so glad you are here to have a conversation with me today. Let's actually start with a little bit of background of who you are and what your passion is.
So first and foremost, I'm a geriatrician, a physician who specializes in taking care of older adults. I've been doing that for over 35 years. I've worked in nursing homes for a similar period of time. But I've also been on the business side of healthcare, starting back in the mid-90s when I ran a geriatric medical management company, subsequently built a large private practice that did a ton of work in nursing homes and assisted livings and house calls, sold it to a public company and actually retired before coming back and running California's nursing home arm of their quality improvement organization. Retired again, and then found myself running a large nursing home chain for a little bit before retiring for hopefully the final time. I mean, honestly, when COVID hit, that entire background just put me in a place to focus on advocacy for vulnerable older adults, for people living in long-term care in nursing homes. And, I like to tell folks, I really have very minimal fiduciary roles. So I do very few things that actually give me a paycheck. So I chair the public policy committee for the California Association of Long-Term Care Medicine. I've been to Washington, D.C. as an individual lobbying on behalf of older adults. So that's kind of who I am and what I do.
So I want to just dig right into this nursing home thing. I started my career in long-term care by doing some small board and care type assisted living buildings in Northern California. I wasn't smart enough to know what I was doing, so it crashed and burned. And I worked for a couple of large companies. I did a 5 or 6 year stint actually down in your neck of the woods in Southern California, working for doing sales for a contract rehab company, which gave me deep understanding of at least California's nursing home business. At that time, I was in virtually every and certainly in I visited at least every nursing home in Southern California, many in Central and Northern California. And of course, because it's so hard to build nursing homes, that probably still applies, that I've been in the, probably 85 or 90% of all, maybe 95% of all the nursing homes in California. And so and then now we've been running this media site for about almost 13 years, like 13 and a half years, talking about the broader senior living industry. And so I say that to say I've kind of got, not as much depth as you, but I've got a lot of depth in this. And there's one thing that I simply do not understand after all this time. And that is that for all of that time, the nursing home industry has consistently talked about how they never have enough money, they never get enough money, they never have enough income. The government needs to fund more money into the nursing home. And yet, every time a nursing home comes up for sale, there are 5, 10, 15, 20 offers, often going for more prices that are above asking. And so if nursing homes are such a bad business, why do people want to buy them?
Because they're not a bad business. There's a demographic imperative that the population is going to continue to get older. There's going to be continued need for long-term care and nursing homes. And at the end of the day, I believe there is enough money. It's just that the money needs to be focused a little better than it has been. So I think you're spot on, Steve, that for all the doom and gloom, folks are still buying nursing homes. So, I'm an entrepreneur. I'm a business person. I look at the market. The market, as you've rightly pointed out, is not cutting and running and getting away from nursing homes. It's doubling down and buying them. So I think that is the best response to all the the messaging that nursing homes are all going to close, they're going under, we can't do it anymore. I would humbly disagree.
So then why is the industry putting out this message, do you think? Is it just about getting the government to turn loose some more money?
So let me do one thing first, because I really, you pointed out you visited many nursing homes, so have I. The people who work in nursing homes are the most incredible human beings on the face of the earth. They have compassion, they're caring, they have all sorts of skills. And so I think we need to separate, and I try always to do this, the nursing home profession, who are all the people, administrators, all the way down to housekeepers, who work in nursing homes, from the industry, which I consider to be the financing behind nursing homes. And the system is set up to focus on the real estate behind nursing homes. It's set up to focus on the related parties. It's focused on all the services around nursing homes. And again, I'm an entrepreneur. I believe in capitalism. I believe in the free market. But in many ways, the nursing home market is not free. And so, look, fool me once, shame on you. Fool me twice, shame on me. When more money comes into nursing homes, that then the profit gets moved into real estate, other services, related parties, and then you keep asking, give me more. Of course they're going to ask to give more, right? Because no one has really put a stop to the structure of the nursing home industry. And honestly, I often say that, and again, there are some tremendous nursing homes out there. There's some tremendous nursing home owners out there. And in fact, when you look at some of the best nursing homes with some of the best owners, not only are they making do with the revenue and the cost structure, but they have 5-star facilities, they have high quality, they have high morale, good staff, and they're profitable. And so that's one of the points I try to make, that there are many examples of successful nursing homes out there right now who are functioning on the staffing levels that the industry is saying is dangerous to the industry. While I would say, and we'll get to this, it's dangerous to the residents and the staff.
So we know that one of the things that, so actually I'm going to back up a little bit before they do that. So as I think I understand it, and you can maybe help with this from sort of a historical standpoint, we had this old reimbursement system that doesn't exist, that was a cost plus system. And the industry became masters, PhD levels at increasing costs because it increased profits because they got a percentage. And it feels like we're still operating in terms of the related parties that will suck out money in that world, even though the reimbursement doesn't work that way. Is that how you see it as well?
Absolutely. And what's interesting is there was a bill in Congress that got passed and became law a few years ago that really took a look at how the similar things were happening in the defense industry. So you had money going to defense where there were all these other companies and middlemen who were pulling profits out, and they improved transparency along the supply chain there. And that's one of the number one things that I've been advocating for, and a number of us have been advocating for the last 3 or 4 years, is just let's get full transparency. Let's see where every penny ends up. And then we can have a legitimate conversation about what resources are truly needed.
Yeah, I love this. I visited a not-for-profit organization in Atlanta a few years ago, where they're almost entirely Medicaid, and they're paying their bills, but they're not, and they're doing a great job with the resources. And they look at that and they say, if we just had more money, we could do it better. We're running on the edge. So, and of course, a lot of it's variable by state, right?
So one of the things I point out about the nonprofits, there's 2 things I'll point out about nonprofits. Well, actually, there's 3. There are nonprofits that are nonprofit operations, but have for-profit real estate and related parties. We need full transparency of those, because that's a whole other ballgame. Then there are nonprofits, a lot of the faith-based nonprofits that are doing the best they can. Keep in mind, they're in markets with an abundance of for-profits that may be driving up the market value of costs of services. So if you have for-profit owners who have for-profit supply companies or staffing, we all complain about the staffing agencies. There are nursing home owners out there who also own some of those very staffing agencies that they complain about the prices of. So when you add that in, the nonprofits are buffeted by the for-profit impact on the market. And that's a nuanced view that a lot of people don't really take into account, that it, to me, is really, really important. And then the final thing is bad habits. You have folks in nonprofits who worked in for-profits and actually continue with some of their bad habits. And I'm a huge believer in the concept of consensus style leadership, servant leadership. And we can talk about it later, there's many studies that show the benefit and value of that type of leadership. And so without the right kind of leadership, you're going to have higher turnover, et cetera. And nonprofits aren't immune to poor leadership. a lot of them have good leadership, but just because you're a nonprofit doesn't mean you're going to automatically have great leadership. And if you don't have great leadership, you're also going to struggle. So I think there's a lot of reasons nonprofits have been affected, but at the same time, I visited a rural nonprofit county-owned facility back in April that's 5-star, low turnover, and the administrator was someone who had worked in a for-profit. And we walked through their P&L, and they pointed out that their P&L was solely focused on the care of their residents and staff, whereas in the company she came from, the P&L had things, line items that had nothing to do with the operation, with the care. And that was just so eye-opening. But the other lesson, the reason I spent my nickel, got on a plane and flew to this rural facility, 5 stars, low turnover at a time when everyone says you can't do it, but there are folks doing it.
So I love this. One of the best nursing home I've ever been in. I wrote about it 2 or 3 years ago. It's in Heber, Utah. It's owned by a for-profit organization. It looks better than a lot of high-end assisted living communities I've ever been to. And they have something like 50%, 60% Medicaid residents. They were very smart, creative, however you want to do it. There's money available in rural communities to do really interesting things. And I will tell you, it is an amazing, wonderful, wonderful place. And so you're absolutely right. It can be done. I actually want to add one more thing to your list on the not-for-profit for considerations. Not so much today, but under prior leadership, Leading Age National was very vocal about how much better their quality scores were than the for-profit industry. And there's no question that their quality scores were higher. I won't dispute that at all. But what they would never talk about is that there are a whole bunch of not-for-profits that don't take any Medicaid or take very little Medicaid. And so they simply had more money to work with. And so it's not a fair comparison. So my question that I'm going to follow that with is this. There's been a lot of talk about I don't know if you will, the evilness of for-profit ownership in senior living. I suspect you've got some thought. I mean, on nursing homes. I suspect you've got some thoughts on that.
You know, I think the challenge is fiduciary responsibility. I have really become a student of the difference between fiduciary responsibility and moral and ethical responsibility. And if I'm a business owner, if I'm a board of directors, if I'm an executive for a for-profit nursing home company, what is my fiduciary responsibility? It's to make money for my shareholders. It's to make money for myself. That is number one. And then there are legal responsibilities. You don't want to do anything illegal. But when it comes to, do you really have an obligation to your clients, to your customers, to the residents, or to the staff? Really minimally from a fiduciary perspective. That responsibility is more of a moral and ethical responsibility, yep. which I think, I honestly think that all nursing home owners should take the Hippocratic Oath, right? Because I, as a physician, took the Hippocratic Oath, and that moral and ethical response. And don't get me wrong, one of the things I'm passionate about, and I like to call it a 3-sided scale. And on the one side, you have finances. On the other, you have operations. And then on the other, you have the clinical. I would challenge everyone out there, how many nursing homes, how many nursing home chains does the clinical part of the scale have equal importance, authority, and weight as the operational and finance? And I honestly I think that is the crux of the issue. When finance is number one, because of the fiduciary financial responsibility, you're going to get what you pay for. So I'm going to avoid calling anyone any names of, or anything like that, because I think if we really focus on the structure, we'll have a better opportunity to make a difference.
Well, as you're talking, one of the things that occurs to me is that, and this is true not just in the nursing home business, it's perhaps in virtually every business, is we find a style of doing business and we just assume that that's the optimal way of doing things. I was talking to a friend of mine yesterday on the phone who owns just a single senior living community, and he was talking about how he's got a new manager who's really starting. They've got the operations kind of where they need to be, and they're starting to dig into things that seem sort of small but are really big. So, for instance, one of the things he talked about was the spoons they use when they're doing medication passes. And they were buying them from a big national supplier where it was easy to buy them from then. And his manager, his supervisor, the person who's managing the overall operation, was looking at it, and she says, "We're paying $1 a spoon, and I can go to Amazon and get 10 spoons for $1." And at one hand, you look at that, you say, man, that's sort of trivial. But if you start doing those things, it starts to, it can be thousands and thousands and thousands of dollars a month. I want to come back to, we're going to end up running a little bit long today. I hope that works okay for you, because I'm watching that clock going, and there's stuff we haven't even talked about, the staffing mandates. But I actually want to come back to a couple of the comments. Jade, if you can put up Scott's first. So I'd love to have you respond to this. Is there a problem of lack of talent in across the organizations?
So Scott, brilliant question. Great question, spot on. Because I had someone on social media the other day make a good point. You could have 6.0 staffing and poor leadership, and you're going to struggle. You can be understaffed and have great leadership, and you can actually do a good job. But here's a caveat, because I've been talking to some administrators lately, and I've been posing that to them. And what they point out is even the best administrators, the best leaders, if you're understaffed, and we'll come to that later, are going to burn out. And so, but I think the key point is we have a leadership skills vacuum in post-acute and long-term care. And that's at all levels: administrators, directors of nursing, medical directors. And, I'm a certified medical director through the American Board of Post-Acute and Long-Term Care Medicine. 10-15% of nursing home medical directors are certified and have some of the basic skills and competencies. How many nursing home administrators really have the leadership training and education? How many directors of nursing? Nurses are a lot like doctors. We are trained in a healthcare system, usually with sort of being beaten from above as we go through, nursing school, medical school, residency, etc. So leadership, in my opinion, actually is the single most important element at the end of the day. And Scott is 100% correct. I have posited that maybe we'd be better off if the survey process actually found ways of looking at leadership, because that's generally going to be the ultimate root cause of most problems facilities have. So I think Scott brings up a great point. At the same time, we can chew gum and walk at the same time. So there are other issues we have to deal with beyond leadership, but leadership is a critical component.
So this is fascinating to me. As you're talking, I hadn't thought about this until you were talking, but I'm sure the CMP grants have been radically revised, and it's causing a lot of pain for people. But what if somebody like, to drop a name, Denise Boudreau, were to create a leadership thing, a program strictly for nursing home administrators, and that you took that $5,000 per building per project and you poured that all into a leadership program for nursing home administrators very specifically? Because the problem is we all face is we don't know what we don't know, and if we can hit that barrier, that could be huge.
So, full disclosure, I didn't come on this program to advocate for a product or program, but the California Association of Long-Term Care Medicine, which I'm been involved with, we're a nonprofit. We actually have a leadership and management and geriatrics 2-day training program that we've had for it's been in existence for 20 years, that we have focused on the nursing home leadership team. And I'm gonna adjust what you said, because there's no administrator in the country who knows everything that's needed to know to run a nursing home. It's the team that's needed.
Right.
So we actually received grant funding through the CDC Strike Team funds. And we are, as we speak, we have gone through 3 cohorts of 1- and 2-star facilities in California, where their leadership team has gone through a 2-day leadership and management training program. And then we're following it up with regular coaching sessions, because you can't just tell people something in 2 days and then expect them to implement it. It takes ongoing coaching and work. Yep. and process. So I think, and it's funny you say this, I do believe that one of the things we're looking at is how can we bring this program to CMP grant funding in various states. I think you're spot on. And as I read through the most recent adjustment to CMP funding, I do think the last item they list is the opening for facilities to reach out to do leadership and management training. And we have all sorts of references and background on why that would make a difference. And so I think that would be a great idea.
Yeah, I think it'd be terrific. So the other comment that came from George Sowers, and I'd like to actually ask this question: does the government need to weed out the rotten owners and ownership groups?
So again, I'm not here to pass judgment. I do believe that at the end of the day, the federal government controls the purse strings for the vast majority of money that goes to nursing homes, Medicare, Medicaid. So to me, if you control the money, you have to have accountability attached to it. I'm a believer in accountability. We wrote a paper in the Health Affairs blog in 2021, February 2021, where we laid out some recommendations related to transparency. And that included, we felt that the federal government should put together a task force to really look at all the transparent data, all the quality and everything, and find ways of identifying what all of us will call the bad actors. So, that's a term that I actually hear folks from the industry where you say, well, those are just the bad actors. Okay, fine. Let's all agree there's some bad actors, and let's get them out of the business. I think, there's an example of something that everyone should agree on.
Yeah, I agree with that. Of course, I'm maybe being a little more optimistic. I wonder if you can take these bad actors and turn them into good actors. A number of years ago, Dr. Bill Thomas wrote an article where he talked about how we should cull the bottom 10% of the herd every year. And he and I sort of battled this out on social media a little bit. He's actually I've talked to him about it fairly recently. He's sort of softened on that a bit, also believing that maybe there's opportunity there to help make people better. But, and I've probably gone a little bit the other way. I'm probably more inclined today to say, there are actually some operators out there that the world would be a better place if there were some operators that just were forced out of business because they're so bad. So
Actually, being practical, being pragmatic, if we strengthen the leadership skills of in facilities, and one of the things in the proposed rule that I'm very supportive of is strengthening the facility assessment. So staffing decisions should be made by folks boots on the ground who are looking at the acuity and their staff and determining what's really appropriate. And this is where maybe I'm a little optimistic and idealistic, but I've seen it work. The best facilities I have ever worked with have the best leaders, regardless of pressure they get from ownership. And that, I think, if we strengthen, a rising tide lifts all boats. And if we strengthen leadership, we push more clarity around responsibility to the facility level. Even the bad actors, if you want to call them that, will struggle to actually impact those facilities. So I do think that there's a path there.
Yeah.
And again, I would lean as you might to do both at the same time.
Yeah, that's kind of where I'm at. Okay, so we're at the end of time, but we haven't even talked about staffing mandates. So we've got to talk about staffing mandates. I just completed a 3-article series that started with a case in favor of staffing mandate, which I'm sure, in fact, I got a number of comments, not so much publicly, but privately, from people complaining that I was unrealistic about favoring staffing mandates. So I'm going to start by, people sort of heard what I think, so I'm going to start by actually having you just talk a little bit about it. And I think we need to approach it in two different ways. We need to talk about it as a concept and talk about it in the context of what's actually been proposed.
So the first metaphor, I love metaphors. If you get on an airplane and the pilot gets over the intercom and says, I want to let everyone know that we're missing an engine today, but it's okay. We're going to manage. I've flown a plane with one engine before. Don't worry about it. The FDA the FAA has granted us a waiver because there's a supply chain problem. Everyone's going to get off that plane. So for the life of me, when we look at evidence-based literature that very clearly delineates, and it doesn't even need literature, walk into a nursing home, talk to a CNA who's trying to take care of 15 people, trying to do all their, clean them up, change their diapers, feed them, do all their other work. They can't get it all done. And so I'm going to just very practically say, I, as a clinician with a moral and ethical responsibility to quality care, I cannot find my way to come to say, well, it's okay to understaff because we can't find people or we don't have enough money. Those things do not connect for me. And then the second part to that, and it goes back to something you said earlier, the folks working in nursing homes, administrators, DONs, et cetera, they've got families to feed. They got checks. They got to earn a living. They're struggling. They're worried about these. I get it. And they're going to say, we don't have enough money because they only see a certain part of the elephant when it comes to the money. They're not privy to all this stuff that is transparent, that isn't transparent. And so I respect their views. But when you really hone in on their views, even staff who are saying, well, we're worried about these mandates making things worse, ask them what it's like to work in an understaffed facility. So that's where I live.
Yeah, put Meg's comment back up. Meg, this is the crux of what we're talking about. I've written about it and I've talked about it before, but my mom spent 7 days in hell. It was called a 5-star nursing home, by the way. And I would go in to see her. I knew the night she was transported there by ambulance from the hospital that I'd made a horrible mistake, and it took us a few days to get we gave it about 48 hours to try to get the nursing home to do the right thing. I had major fights with the DNA, and it got just barely better. But I would walk into this building and there'd be these call buttons going off, and I'd be looking and the CNAs are just zoom. They're just running from one to another. There were nurses sitting at the desk who were completely oblivious. Culture problem. If you needed to go to the bathroom and you push the button, you better expect to wait 30 minutes to get something. And this is not, and it's so easy to get mad at the CNAs, but you know what? The CNAs had too much work to do. It wasn't their fault. It was the leadership fault, the staffing fault, and they are just it's infuriating. And I love the airline example. My example has been that you know always sort of along that same line is that when you get on an airplane, you're really glad that the FAA says they've got us to have a certain number of pilots and flight attendants on that airplane, right? Or if you're going to put your kid in your child or grandchild in a daycare, you're certainly glad that the government has minimum staffing ratios for those daycares. Now, I'm going to come back to the argument that I heard actually from somebody just today who said, well, the problem with staffing mandates is that if you put in staffing mandates, then all the businesses are going to do is just meet the staffing mandates and nothing more, even if residents really need more. How would you respond to that?
So facilities that are already exceeding the required numbers, those are the ones that get it. They're the ones that know what they need to do. They're not going to reduce their staffing. So I totally don't buy that concept. Now, for the ones that are looking at the dollars and cents rather than the acuity and the needs of the residents, yeah, that's still one of the problems. And that's why the facility assessment is so important, so that even with a required number of staff, those facilities under a survey would have to say, well, we did our facility assessment and showed that this staffing was appropriate and adequate for the care we need to deliver to these complex residents. And so I think those are the two sides of the pressure points that we can apply. And a final thing, one thing I completely agree with the industry on, leaving out the LPNs makes no sense. And there is a great fear that, and this is realistic, that facilities could literally, under the present proposal, fire their LPNs, replace them with CNAs. Now, on a CNA side, that'd be good, but anyone who's worked in nursing homes know the value of LPNs. And this whole thing that, well, we don't have data on the value of LPNs. We don't have data because we haven't studied LPNs. So you got to be careful when you say we don't have data. If you don't have data because you've studied it and the data doesn't show something, that's one thing. When you don't have data because you just never studied it, most of the studies that look at LPNs lump it into CNAs and RNs and LPNs and is really not specific to LPNs. So, but I am really worried that LPNs could get let go. That is a realistic fear that many of us have.
Yeah, I guess when I look at what was proposed, part of what has gone through my head at looking at the existing proposal is that it's so flawed that it almost feels like there was pressure for CMS to put out something. And so they said, yeah, okay, we're going to put out this thing that we know is never going to pass because it's stupid, but at least we can put out something. And then we won't have to go to fight for the industry because so many things, wrong with it. It doesn't really address the funding, doesn't address the availability of staff. What about the question of whether there are enough people to staff minimums?
Yeah. So one quick comment on CMS. I'm going to withhold judgment till the final rule comes out because I think there is political pressure, there is influence, there is a lot of stuff. I think things affected the proposed rule. Let's see what the final rule shows, and then we can come back and we'll have another talk about that. In terms of the thing of, are there enough staff? This is where I want to push back. Studies on consensus style leadership show that you can dramatically reduce turnover with the appropriate leadership styles. So one of the things no one talks about is turnover. Turnover is huge in facilities across the board. If you dramatically reduce turnover, you are reducing the need of additional staff, because a lot of these folks these days, when they leave, they're leaving the industry. And so if we have better wages, better leadership, we can keep the people we have. And right there, maybe we cut the staffing needs in half. The other thing is, I even hear staff say, no one wants to work in nursing homes. And you know what I always do, Steve? I look at them and say, what about you? You're here. And yeah, but I'm different. Well, no, you're not. You're a compassionate, caring human being. There are other compassionate, caring human beings out there. Look, when I trained as a physician, people would be in the hospital for 6 weeks. Now they're in the hospital for 3 days and they go to the SNF. Nurses in hospitals actually don't have continuity with their patients. They don't actually have a lot to be gratified for. I could make the case that if we paid a living wage, paid competitive wages, respected and treated and led our frontline staff well, that we would have no trouble getting folks to go into nursing home care.
So I agree with you 100%. I think that there are something like 5.5 million people who work in fast food today. They're easy jobs to get. They're pretty hard jobs to do often. We mischaracterize being a CNA as all about wiping butts. If that's really all they did to every day, it would be terrible. But you know what? Most CNAs love what they're doing. And I've got a story that we're going to be doing in a few weeks about a nursing home in New York that pays union wages. So they're not paying extravagant wages. Their turnover with CNAs is 10%.
Yeah.
10%. It can be done. It's an amazing, wonderful story. It's all about creating a leadership style that does that. And of course, the last argument against the staffing mandates is that there's not enough money. You've already sort of debunked some of that because there are people who are doing it with that money. But the other thing is almost certainly coming with that will be increases from the government. If they don't, there'll be lawsuits. And so I just don't see it.
Yeah, you said it really well. I mean, I honestly think when you look at, if we really have full transparency, and you actually even look at industry estimates on how much it would cost to bring staffing levels up, it's about $16 per resident per day. And so, I think the money's there in the system. I think we need transparency to find it. I think that's the answer there.
Well, Michael, we've gone way over longer than we usually do. I can't tell you how much I appreciate this. I know that we're going to have to do a part 2 when the revised proposal comes out. I appreciate all of those of you who have commented and added fuel to the thought for our conversation. And so with that, I thank you for joining us, and we will see you back next week with another show.